Hello class, this is Leshi from Atlanta. Today we are discussing about the ABO incompatibility hemolytic disease in the newborn. So the objective is just to define the cause of ABO incompatibility and to discuss the symptom and just to list down if there is any tests that help to identify hemolytic disease, and if there is any treatment that helps to cure the disease or any other treatment, just we will discuss in this presentation. And at the end we summarize the ABO incompatibility hemolytic disease in the newborn. There are keywords that we hear here and there throughout the presentation. So like hemolytic, ABO incompatibility, jaundice, DAT, these are words we hear again and again throughout the presentation. So what is hemolysis? Hemolysis is a situation when a newborn red blood cells are destroyed by IgG antibodies produced by the mother. Mostly it happens at delivery when the placenta detaches from the mother. So if a teeny drop of blood goes from the mother to the baby, which is, if it is different, let's say the mother is O and the baby is A or B type, it might be cause hemolysis. So there are three types of hemolytic disease in the newborn. The first one is ABO incompatibility, second one is RH incompatibility, and the third one is hemolytic disease other than anti-D. Might be anti-S, might be anti-K, might be anti-M, and others. So throughout the presentation, our focus is the ABO incompatibility. Hemolytic disease in the newborn, when the maternal antibodies destroy the fetal red blood cells, it causes hemolysis. If a person is hemolytic, his or her ability of the blood to carry oxygen to their organs and tissue is very limited. It is very restricted. When the body responds to that hemolysis situation by producing more and more red blood cells released prematurely, they are unable to work the job of the mature red blood cells. Since they are immature, since they are continuously produced by the bone marrow, they are not strong enough, they are not mature enough to do the job of mature red blood cells. So since they don't do the job, this hemolysis red blood cells is not transported to the right place, and it will be hyperbilirubinemia, and that hyperbilirubinemia is cause jaundice. When we look this picture, our focus is here on the placenta. The only type that cross the placenta is IgG. IgM is not cross the placenta. So this picture is from our immunology class. So as you remember, if you look here in the picture, is the only one that cross the placenta is IgG. So IgM is not cross the placenta. That's a key thing that we have to learn here. ABO incompatibility in hemolytic disease in a newborn, when a person is receiving blood from someone with a different blood type, it might cause his or her immune system to react. So always our body gets something different, foreign to its own, it always reacts. So in the case of this one, when the baby's blood got something different, it reacts right away, and it causes hemolysis. In the case of ABO incompatibility, especially in the newborn, this case is mostly the mother is O type and the baby is A type or B type or AB type. When we look its occurrence, the ABO incompatibility in hemolytic disease in the newborn is common. It's very common, but it is not very severe compared to the other two, like RH incompatibility or hemolytic disease in the newborn other than D, like anti-K or anti-Kaylee or Defi or others. ABO is not severe, but it is very common compared to other races. African American get high ratio compared to the Hispanic, compared to the whitest. The ratio of African American ABO incompatibility is higher than the others. So what are the signs, the sign and the symptoms? The symptoms of jaundice is it's the accumulation of high bilirubin in the circulation. Incompatibility of jaundice begin in the first day of life. When the baby born, it might be happen jaundice. In a rare case, jaundice might be sign of infection. And when the baby has too much bilirubin, the skin and the whites of their eyes start to change yellow. But we have to make sure that looking somebody on somebody's skin yellow, or just looking somebody's eyes change to yellow, the white part of eye change to yellow, we can't jump and conclude this person is jaundice. We have to do the laboratory tests. Jaundice might happen on the first day. We have to make sure that as soon as the baby deliver, we have to make sure that the baby is tested and secure about his bilirubin level. So laboratory test is a key thing. We are not jumping to conclusion by looking their skins, by looking their eyes. After all, what is the consequence? Why jaundice is scary? So jaundice is jaundice goes away with a mild treatment, but if it is untreated, it might be cause kernicterus, that is the worst situation, which might be the baby might be end up hearing loss, might be end up vision problem, improper development of teeth enamel, and permanent intellectual disabilities. So to avoid all that, the baby should be treated on time. Jaundice is related sometimes with other diseases like liver disease, like hepatitis, like infection. They associate. So whenever we diagnose a baby with hepatitis, when there is infections, we have to make sure aware that his jaundice situation also. Laboratory findings. So just by looking the baby, we can't jump for conclusion. We have to make sure that he have a positive DAT test, his bilirubin level is above. There are different levels from the first day to the second day. Within 24 hours, there are different levels. We have to make sure that the baby is on that level. When we diagnose, when we look his blood morphology, his nucleated red blood cells presence, anisocytosine situation, and the polychromasia morphology of the blood, is those things are indicated that the baby is suspect for jaundice. When we look here, that is taken from jaundice baby. When we look MCV, it is 109.2 and his hemoglobin is 18.2. But there is no wonder that having this high number of MCV and hemoglobin in baby as catch our eyes, because it is very common. Babies may have that high MCV or hemoglobin or high hematocrit level. But when we come here looking near anisocytosis, looking near microcytosis and polychromasia, it helps in addition to other tests the baby is suspect or not. So when we look the routine chemistry of jaundice, let's take this baby on 26. As soon as he born, his bilirubin level is 1.5 milligram per deciliter. On next day, within 24 hours, his bilirubin level is 6.1 milligram per deciliter. It is very high. So our guideline is a pediatrician reference range for bilirubin in a full-term infants. A cord within 24 hours, it should be less than 1.8 milligram per deciliter. But if the baby is a full-term infant within 24 hours, it should be less than 6 or is equal to 6. If it goes more than that, the baby is suspect of jaundice. This is a guideline for the pediatrician. So when we go back to the previous slide, the first time the baby got 1.5, that's okay. And when we look after 24 hours, the baby got 6.1 milligram per deciliter, which is jump the threshold. It should be less than 6. So this baby must have get a mild treatment, might be sun treatment, might be blanket treatment. He have to have some treatment because it is a jaundice suspect. Treatment of phototherapy is the best therapy that we can give for the baby. That's a blue light therapy, converts bilirubin and excreted in the urine and feces form. So phototherapy helps to break bilirubin and excreted in the urine and feces form. Eye shield is very important. We have to cover the eyes of the baby because of the ray that it comes out of the phototherapy that damage their eyes, so it should be covered. But the baby putting the baby near the window is another treatment. Sunlight is break the bilirubin level. Phototherapy should be used in healthy infants. If the baby has another related disease or some infection or worse situation, we don't do phototherapy. Infants receiving phototherapy may continue to be breastfed or bottle feed, so we have to keep feeding them because feeding make them to feces, make them to excreted the bilirubin level, and it helps us to get the baby healthy. So this picture is indicate phototherapy, how the phototherapy is given to the baby. Kernicterus is a situation that causes permanent damage of the brain when the bilirubin level is high, and if it is untreated on time, it causes permanent damage of the brain. The damage area have a bright yellow color. Unconjugated bilirubin crosses the brain and create the damage. Bilirubin is considered toxic to nerve cell. When the total serum bilirubin level is greater than 25 milligram per deciliter, it needs blood exchange. In this situation, when it goes way far, we have to do the blood exchange. This is always in the recommendation of the doctor, and it needs follow-up of the doctor. It also, the donors must be, it's highly recommended one donor for the blood exchange, and still keep feeding the baby, help us for the treatment. To summarize all this, when IgG antibodies produced by the mother against the baby's antigen, which is absent in her, and destroy red blood cells of the fetus. There are 3 types of hemolytic disease in the newborn. That's bioincompatibility, Rh incompatibility, and hemolytic disease in the newborn other than anti-D. Laboratory testing is very important. We are not jump to conclusion without any laboratory test. We have to check the DAT level, we have to check the bilirubin level, so that helps us, or in the looking another morphology of the blood help us to make sure that the baby is jaundice or not. Proper early treatment helps us make the baby, and also make sure the next pregnancy is safe, because in the Rh case it affects the next pregnancy. So treatment is always important. Bioincompatibility in the newborn is usually mild. Thank you for listening for the presentation. If you have any question, you can email me. Thank you very much and have a wonderful day.